Thank you, members. Now that our witnesses.
Thank you. Julian Morse, MLA for Frame Lake here in Yellowknife.
Hi, welcome. My name is Kate Reed. I'm the MLA for Great Slave.
Good afternoon. I'm Shauna Morgan. I'm the MLA for Yellowknife North.
Good afternoon, everyone. My name is Robert Hawkins. I'm the MLA for Yellowknife Center, and as always, I give a warm welcome and shout out to our millions of social media subscribers for this very important public discussion.
Thank you, members. Now I'll turn to Ms. Yakalaya online.
Good afternoon. I'm Cheryl Yakalaya. I'm the member for the DETRO. Thank you and welcome.
It's Jane. And I'll just turn to Ms. Leilyn Armstrong for the record. Just introduce yourself.
Jane Wayallen Armstrong, MLA for Morphy, Klitschko Region.
Thank you, members. Today we will receive and I'm Kieran Testart. I'm the member from Range Lake and temporary chair of the Standing Committee on Social Development. Today we will receive a briefing from the public administrator on the public administrator's work plan for healthcare services in the Northwest Territories from the Honourable Lisa Semler, Minister of Health and Social Services. Members, I'll remind you again that we are being streamed live. We had a bit of fun with that when we started this meeting. So I will remind you and all witnesses, please direct your questions and comments to myself as chair and wait to be recognized before speaking to help us have a smooth meeting. I will now pass it over to the Honourable Lisa Semler with your presentation. Madam Minister, the floor is yours.
Thank you, Mr. Chair. Good afternoon, everybody. First of all, I'd just like to introduce my staff. And so we have the Deputy Minister, Joanne Chiquetto. I have the Public Administrator, Dan Florzone. I have Kim Riles, the CEO of NTHSSA. And I think we have some staff in the room, Perry Heath, ADM, the department, Haley, and the advisor to the deputy, and we have Alan Stenzel, who is the advisor to the public administrator. So I'd like to get into just a few things. So as everyone is aware, that replacing the NTHSSA Leadership Council with a full-time public administrator was a major step in our work to ensure long-term sustainability in the Northwest Territories healthcare system. As we continue to work through the shift in governance, it's important as ever to maintain strong regional input into our decisions. Regional wellness councils continue to play a vital role ensuring regional voices are heard and reflected in our work. To strengthen that connection, I will now join the public administrator when he meets with the chairs of the Regional Wellness Council twice per year, starting in a few weeks on June 12th. While this has not been the practice in the past, I believe it's important for me to hear directly from regional leadership and to remain actively engaged in these important conversations. As you all know, here in the Northwest Territories, we face the same profound challenges affecting healthcare systems across the country. Globally and nationally, there is a shortage of trained healthcare professionals, along with an aging population. While we are so grateful to have our elders around us for longer, we must ensure that we have the staff and capacity to care for them as close to home as possible. In the Northwest Territories, these pressures are amplified by the realities of delivering services to small, diverse populations across vast territory. These difficulties have resulted in real inequities in care between residents of the capital and those in smaller communities. This is difficult work, and we are fully committed to addressing these challenges head-on. That means modernizing how we work with medical professionals, how we support frontline innovation, and how we recruit and develop a strong, resilient workforce. I'm committed to reporting on our progress regularly to both Standing Committee and to the public as we do the work to address these challenges. We are advancing national conversations on physician licensure, strengthening incentives for locum physicians, and reducing our already limited reliance on agency nurses by investing in training and retention. These are just a few steps we have taken to help ensure we remain competitive with other jurisdictions and improve continuity of care across the territory. Transforming a system as complex and diverse as ours cannot be done overnight, and we are not interested in settling for quick Band-Aid solutions that do not address the root problems. Since his appointment 5 months ago, Mr. Florazone has and will continue to provide dedicated full-time leadership that will drive this transformation. He has moved quickly to address key priorities like budgeting and deficit reduction while consulting with the system's major stakeholders, including leadership across the authorities and the department, frontline staff, and the regional wellness councils. I know that some members, have expressed concerns publicly. While I respect their position, I want to take a moment to clarify some of the concerns outlined, such as challenges to compensation or altering collective bargaining processes are complex cross-government issues that require collaboration, and I am committed to working with my colleagues to find solutions together. Before I hand it to the floor, Mr. Florazone, I'd like to take the moment to speak to the importance of this committee and others like it. Standing committee are a vital part of our consensus government. They provide a forum for open, constructive dialogue between departments and regular members, a space where progress can be examined, concerns can be raised, and solutions can be shaped together. I want to emphasize that outside of session, these scheduled meetings are appropriate and most effective venue for that exchange. When we rely on the committee process, we ensure transparency, accountability, and the respectful collaboration that NWT residents expect from all of us. With that, I'd like to turn it over to Mr. Dan Florazone. He will walk you through his early observation and outline his work plan to help strengthen our health and social service system. Thank you, Mr. Chair.
Florazone.
Thank you, Minister. Thank you, Mr. Chair, and members of the committee. I want to extend my appreciation for the opportunity to be here today to present. I'm going to try and keep my comments brief, but I want to walk you through the work plan. I've got before we get into the PowerPoint and the work plan details, I want to start off by saying how honored I am to be in this role as the public administrator, and how incredibly important this work is to the people across the territory. It's not lost on me, having been born in Yellowknife, the importance of health services, and a lot has changed in 61 years. That's a good thing. But there are and have been erosions that have occurred, and I want to address some of the challenges and opportunities, but also some of the advancements that have occurred in the years preceding this presentation. So as public administrator, I've been tasked with guiding the organization through periods of transition, and there's no doubt we're going through a period right now. Now more than ever, we're seeing increased demands across all jurisdictions in Canada, and some of this is international, but really it's the need to support the health sector workforce, and the teams of providers that are providing care each and every day. Our senior population has doubled in the last decade. So we may not have seen a large increase in raw population numbers, but an aging population has meant an increase in chronic disease, an increase in the call for those types of supports. And we're also seeing a shift, and we'll get into this a bit, but the feedback we've been hearing from regional wellness councils around drug use and drug of choice, and some of the increases and knock-on effects that occur with population needs. In addition to seniors and aging, we have health inequities that have become and are quite pronounced. For our Indigenous people, they're widening, and demand for health and social services, that demand is growing. There are challenges across all jurisdictions in the recruitment and retention of health and social services professionals. And we're seeing that in urban centers, as well as the ongoing challenges in our rural and more remote areas. Across the north, but specifically in Northwest Territories, there are tangible inequities when it comes to access to care and services outside of Yellowknife. So this isn't just a matter of what happens here in the city. We're seeing those inequities far more pronounced outside of Yellowknife. And these challenges require urgent attention because they not only affect those residents living in smaller regions and smaller communities, but they impact the volume and demand on services in Yellowknife. So in addition to a shift in population, we're seeing an immigration to the urban center in Yellowknife that's creating a demand, taking up whatever capacity we've had, and obviously causing stress and strain on systems. So improved care at home or as close to home as possible is really key. And I have had the opportunity of hearing members speak to the importance of restoring, establishing, improving local services. And the mantra that I've been sharing is care at home or as close to home as possible. I've spent the past few months focused on budgeting and deficit reduction planning, but also on building relationships with stakeholders such as the Regional Wellness Councils, the former Leadership Council chairs, and the Northwest Territories Medical Association, whom I've established monthly meetings with. These meetings are really in order to better identify existing challenges and to work together to create solutions. I've also had the privilege to participate in 6 of the Minister's Regional Staff Engagement Sessions, and at these sessions I had the opportunity alongside the CEO and senior leadership to engage in dialogue directly with the staff and physicians on the topics that matter to them. Through these conversations, we've identified several key priorities, and those priorities include incentives, attractive measures to create a more attractive workplace and work environment. Also, staying competitive with contract rates and staff incentives. It's also the quality of work, the administrative overburden that occurs in these positions where streamlining is necessary. We've also heard about enabling technologies and the need for virtual care and AI. I've also spent a great deal of time understanding the structure and operations of the NTH SSA. As members are aware, the authority is one agency that works within that broader context of the health and social services system. As the largest entity, our role is central to the success of the system, and I'm optimistic there's an opportunity to work with our partner stakeholders to make real and tangible progress. The authority is doing a lot of things they and residents should be proud of, and there are challenges, there's no doubt. There's a strong foundation, in my opinion, and I come in with 35 years of health administration experience with students that I've had from across Canada and a pretty good knowledge of high-performing health systems across the globe. We have a strong foundation and a very engaged leadership in place here locally, and they have a genuine desire to see system improvements. Each day, these people are working hard, and I've come to appreciate their work is largely not visible to the public and to yourselves. So I believe there's room to improve this. With a broad strategic perspective, my role is to enhance access to care and create the conditions for long-term sustainability of the authority. While there are successes, and I'm seeing progress each day, there's still so much work ahead, and these opportunities form the focus of this work plan. I want to conclude by saying my position is not permanent, and I think that's pretty obvious to members. Once the action in this plan or those actions are implemented and the necessary improvements are made, my role will naturally phase out and an updated governance model will be established. This ensures that the authority becomes self-reliant and fosters internal and community leadership for sustained success. This work can sometimes feel slow, but if you look at and across jurisdictions, you'll find that there are no quick fixes. We'll have short, medium, and long-term needs, each requiring a specific set of actions. So I'm confident that we can get there, but we need you. We need MLA support, community participation, leadership, staff, physician engagement to make improvements to our systems. And I hear in your words, that's what you want and expect of the public administrator. So if you can give us the space to implement them, these efforts will lead to lasting success. Now I'd like to direct your attention to the PowerPoint so we can walk through the items outlined in the work plan and address any questions that you might have. I'm sorry, I'm not sure if the PowerPoint is up.
Well, they'll put it up.
Okay.
And then this is to move forward once
Thank
he
you.
has it.
Sir.
Members, you all have this in front of you. Just proceed.
Okay.
Thank you so much, Mr. Chair. So just in terms of the highlights, I'll hit the high marks. This work plan obviously builds on the mandate of the 20th Legislative Assembly of the Government of Northwest Territories. The Minister of Health and Social Services also issued a mandate letter to me, and that has informed the development of this plan. The priorities focus on enhanced access to care and long-term sustainability. Obviously, we have other partners that we need to work with, including the Sustainability Unit, who I met with the first week of my appointment. So I've divided the work plan into 4 priority areas, each with specific commitments, actions, and timelines. If we go to the next slide, here we go. I've focused early weeks on onboarding actions to support these priorities. So everything from legislation to policies to plans. I've looked back at minutes. I've met with regional wellness councils and council chairs to try and really get a sense of both the history and the current state within the territory. So these months have been spent on not just reviewing material and written word, but also building relationships with stakeholders. The onboarding actions, I believe, lay the foundation for enhanced effectiveness and alignment with all stakeholders. The real key you'll see as the theme in this work is engagement. And it's engagement at the community level, it's engagement with the regional wellness councils, it's engagement with communities, and it's engagement with providers, including physicians. So the onboarding portion, at least the initial portion, is complete. And I feel that it's given me a really good sense of some of the work done to date. But also it's really important to note here, a document that's written, what I'm looking for is also confirmation in speaking to people that these plans are actually making a difference. So data, evaluation, planning, all important. Going, seeing, meeting, speaking are critical. So priority area 1, I mentioned 4 priorities, and priority 1 is a shared priority with this legislative assembly, and that's improved access. I suppose if we were going to extend this, it's improved access to quality care. So improving access to both health and social services is essential, obviously, to ensure the health and well-being of residents. The work will require strengthening relationships, ongoing engagement, and really understanding more deeply the needs and the issues that people are encountering each and every day. So since my appointment, I've obviously heard the stories and had the opportunity to hear from people who live and work in the smallest communities in the territory, such as those, and I'm going to use the example of Decho. I was also in Clecho. I'm planning to, and you'll see it reflected later in my plan, I'm planning to get to every regional council. I have been to Hay River. Even though that's outside of the authority, really critical that we have a strong working relationship with Hay River. So last month, the CEO and I visited Jean Marie River and met with the wonderful community health worker who's both from that community and serves their health care needs day to day. We believe the way care and services have been delivered in these cabin communities for many decades needs a critical look with an equity and an anti-racism lens. This is what the first item under this priority will seek to address. In terms of more detail, We're now identifying in the Decho region the potential for a demonstration project. This demonstration project I'll get into in just a little bit more detail, but I hope to answer some of your questions on how demonstration is intended to spread everywhere. We want to learn by applying, by measuring, by engaging in the Decho region to 6 small communities who have described their experiences being at the end of the road. What we want to demonstrate is that they're actually at the start of the road. What is it that creates the need or the crisis that requires them to travel down the road to a health center or to their local hospital, ultimately to Stanton or even to the south into Alberta? That journey is a critical component of my work plan, to try to understand the journey. The next item under this priority addresses our ongoing partnership and collaboration with the Department of Health and Social Services, and this has to do with the Primary Healthcare Reform Initiative. I like to say that the Northwest Territories invented primary care in Canada. And if we look at what was outside of Yellowknife, what was maybe the result of what had to be because of constraint. Working together, teaming up, trying to deliver services in spite of the constraints that existed, resource constraints, human resource constraints, other constraints. When I think about it, we've seen a bit of an erosion that's occurred over time, and some of this has been under the banner of accreditation or standards. So we're working away at trying to make these improvements. So I had the privilege of participating in the briefing that this committee received on the topic of primary health care reform and also medical travel. So I've got to say that that is the basis and consistent with my work plan. Let's go to priority area number 2. And it has to do with system sustainability. And I want to refer here to sustainability as not just financial. It's really about maintaining or improving operations, including the delivery of high-quality care and services, without compromising financial stability and long-term sustainability of the health and social services system. So we can reduce costs, improve care, and seek better outcomes, all 3 at the same time. Improving of the sustainability of the workforce is a key component of this, and we as an authority hold the lead on drafting the Health Human Resource Strategic Plan, also known as the People Strategy for the health system. As committee may be aware, the previous plan ended last fiscal year, and this year's work is focused on a bridging plan that wrapped up a number of items from the previous plan that were delayed, and they were delayed due to factors like the pandemic and other emergencies that were experienced in the territory. This year has also been spent assembling a new people strategy, so something that we want to present, and with the permission and support of the minister, to return to the committee to let you know of the activities that are underway. We're set to launch that newest plan in June of 25. So we've got some really tight time frames, but it's been the work that's been unseen and behind the scenes being prepared. What we see in terms of this people strategy is taking what we've heard and what we're doing and giving people a direct line of sight to what it is that we're doing in response to what we've heard. So there've been a series of town hall forums that the minister has sponsored. I've been out and about visiting. We're going to continue to collect information from numerous sources. We're turning and translating that into an action plan that we hope to release and, with the support of this committee, implement in June. This includes, of course, the Indigenous Employment Plan, which is a plan that I'm sure this committee is quite familiar with. And I can't help but notice that while the government, its employment is, I think it was around 40% of Indigenous people employed within the government, the GWT. We have a situation where we're closer to 20% in the health sector. We've got a lot of work that needs to be done here in terms of Indigenous employment. Now, part of this is anecdote, but it all starts with an observation, and the observation is that somehow and sometimes our entry-level positions set a bar that possibly could be adjusted, and we could train on the job as opposed to requiring that training to gain entry-level employment. I know that there's great government initiatives by way of what's been done to date, but I want to make sure that within our planning, we look hard at opportunities for our youngest and most vibrant population to gain employment, so that we're not totally reliant on either foreign or southern employment. So the people strategy itself is really just a document, but the real work will be done by the actions that come from it, where we'll work with our staff and physicians to create meaningful action and to measure and report on progress using data metrics that are set out in the plan. Now, I don't want to presume on behalf of the minister, of course, but I think it's safe to say that I recognize this plan will be an item of significant interest to this committee. Now, it's important to touch on balancing the budget. We are setting out a plan to balance the budget in 2 phases. And that 2-phase approach is really a 2-year plan to come in at a balanced budget. Now, part of that is dealing with the administrative expenses and efficiencies that I see and view as we work together. The other part is to look at revenue. And part of that revenue is obviously seeking, through the minister's leadership, full financing by the government, from the federal government, for things like medical travel that we talked about at the last briefing. So I've been looking at the positions, the organization, the structures, and there obviously is work to be done here in getting to a place where we not only improve care, improve access, but reduce cost and seek enhanced revenues. So these increased trends, by the way, in spending this is not unique to the Northwest Territories. Healthcare costs are up throughout the country, and it's my job to work with the leadership of the authority to identify opportunities to reduce expenses while maintaining access to programs and services that residents rely on. So this year, the approved budget for the authority will see a reduction of operational expenditures and includes fiscal restraint measures designed to reduce administrative expenses and to increase the focus on efficiency and cost avoidance. We'll also be reviewing opportunities for reinvestment of funding to priority areas that will improve access to care and services, particularly in the smaller regions in the Northwest Territories. Now, I don't want to create an impression that this is either or. We're going to improve services in Yellowknife, but if we can concentrate on access outside of Yellowknife, maybe we can curb some of the demand and pressures that our major hub in Yellowknife is experiencing. It also is an opportunity to curb costs by reducing the demand for travel. In other words, we get upstream of what causes the travel in the first place by delivering services closer to home. These may include virtual care, point of care. This could be areas like itinerant services. And really, where do these ideas come from? They come from the very teams that will be engaging, including the physicians. This is no small task and will take work of other partners such as the Department of Health and Social Services, the Department of Finance, the Healthcare Sustainability Unit, who we're working closely with, and we're committed to ensuring that we're at a balanced position by the end of next year. Next is governance. So I think my
Clicker's not working.
Thank you so much, Mr. Chair. Governance provides the framework with which decisions are made. So it ensures accountability, it sets the direction for the organization's strategies and objectives, and it's a critical component necessary to the success of the authority. In dissolving the Leadership Council, and with my appointment as public administrator, I'm charged with the duties and responsibilities set out in the legislation and organizational bylaws. You'll see these core responsibilities reflected in the first two commitments under this priority. The third commitment relates to a specific deliverable that the minister has requested of me. And I've said in my opening comments, I'm not here for a long term. The minister has shared that she is committed to returning a governance approach for the authority that allows for NWT residents to participate and provide the organization with oversight and direction. I've been tasked with providing her with my expert recommendations on how this could be designed for her consideration, ultimately for her decision. I'll steam through to priority area number 4, which is streamlining administrative processes. And I'm sorry, the slide isn't advancing. So administrative processes have been bantered about and discussed. And in every jurisdiction, it's really important to think about those things that are barriers to us getting to care. It could be the forms we complete, the processes we establish, and many of these, while they may be required, it's important to spend the least amount of time, the most efficient method possible to be able to complete the administrative tasks. So we actually have many activities that are currently underway. As areas for improvement are found, it'll improve efficiency and ensure processes are less burdensome, can reduce cost, improve accuracy, leads to quicker decisions and approvals, and can boost employee and patient client satisfaction. The final area of priority that I want to share with you, obviously, is an area where I personally have seen opportunities for efficiency, improvement, and reduced waste and work I've led in past roles in Saskatchewan and other locations. So this is my pet area, streamlining administration, smoothing out these processes. So I've heard from leadership, from staff, and from physicians that everyone sees opportunities to streamline and to be nimbler and more responsive. I want to ensure that this is enabled, and this priority is a commitment to seeing this occur both within medical travel, as we've talked about, which you'll see the first commitment, and other areas as well. So I want to be able to instill improvements that are continual. We've talked to the physician leadership about 52 improvements in 52 weeks. It's the kind of improvements that we can see by Tuesday of next week. The reason why I want to instill this kind of charged up improvement cycle is that we can sit and wait for the long-term stuff which by its very nature takes time. We also have mid-range work that's currently underway, and it will take time. But what we need to do is build some immediate hope. The types of improvements that can be made immediately are the small pebbles in people's shoes that get in the way of them providing care and leaving their day feeling good about the work they've done. So in addition to that, we will be looking at the big stuff. We'll also want to review the structure of the organization. We recognize that the authority turns 9 years old at the end of, I believe it's the end of this summer. And it's seen significant change. It's been through a pandemic. We've seen the crises, but also the progress and growth in this interval. It's time for a review. And I'll plan to work with the CEO and hear from other stakeholders on how the organization's structure can be adjusted to ensure maximum efficiency and effectiveness. So part of this work is to provide recommendations to the minister about the way that the authority operates within its relationship with shared functions, finance, HR, as we believe there may be opportunity to become more efficient in some of these areas. So in closing, I'd just like to say that this plan, with your support, will make possible a feeling of hope, a more attractive work environment where staff and physicians feel engaged, a team-based effort, a real link back to community, and wanting to make sure that we focus in not just on the needs of what's, where the alarm bells are being sounded daily, but also the needs and gaps that occur in access to care in rural and remote areas. Thank you, Mr. Chair.
Thank you, Mr. Florazan. Committee will now turn to committee members for questions. I'm going to give members 5 minutes for back and forth. So if you could be mindful of that with your questions, and please, witnesses, be mindful with your answers. I know, Mr. Florizone, you're a storyteller by all accounts, so if you could just make sure you give enough time for the members to use that full-time block. So we'll now go to Mr. Hawkins.
Thank you, Mr. Chairman. Yeah, thank you. I'm here today to find out some specifics. I appreciate the virtue signaling of the tone you wish to bring. Of course, that's very important, and that's always a good introduction as to what people should start to sense or perceive as to the type of work you're going to do. But when can we expect a specific action plan? Because when you say, we're going to remove the pebble from the shoes, and, we're structural organization and operational efficiencies, it's really hard to know what that actually means specifically. I mean, I know what operational efficiency means, but it also means nothing too at the same time, which is it's such a big phrase. In other words, are you going to go through budget by budget? Are you going to zero-based budget? Like, that's the type of action plan that I'm curious about. So let's start with when can we expect some details as opposed to the broader perspective? Thank you.
Thank you. Mr. Florizone.
Thank you very much, MLA, for the question. The work has actually started. So I'm not a big fan of saving up in a plan for action. And what we can start to do is, through the minister, start communicating some of the actions and activities that have been underway. So we've got, just yesterday, we were going through some very promising practices that have captured the attention nationally. And this has to do with our response as a hospital in Stanton to violence and those situations where you encounter threat and those assessments that are necessary. So we can start talking almost immediately about the very specific actions. Now, for you to ask me about, Mr. Chair, about specifics, I got to tell you that one of the wonderful things that I've experienced is that the specifics are actually coming from the teams. I can't guarantee that everything we try is going to work. These will be team ideas that are tested with quick cycle evaluations, and where they fail, we're going to learn, and we're going to be persistent as hell by stepping up, picking ourselves up, and trying again. So the idea that there is going to be an attempt to 52 improvements, there may be some things we try. These are staff ideas that may not work, but by trying small things and testing them on a small scale, we will also risk very little. These are small tests, small changes, small failures if they turn out to be failures. This is the kind of inspiration we see.
Mr. Hawkins.
Thank you, Mr. Chairman. I appreciate the PA's answer, and I'm looking for a little more detail, sort of meat on the bone. So in other words, I'll give you an example. I'm just going to make up a specific. It may be something you wish to examine. It may be something you don't think is worth examining. At this particular second, I'm not going to weigh in the correctness of it. So for example, nursing and doctor ratios, are you studying that? That's the type of detail. And when are you studying that? Do you intend to study it within 2 months? Do you plan to, say, take a strategy of ensuring that we reach out through a survey through all of them, compare that to national standards, and find out what is balanced through? That's a specific action item. If you don't want to write a 20-page report as to our plan to study it, I'm on the same page with you on that one. That said, that's the type of specific answer I'm looking for. I could go through a few more examples, but I mean, I think that's probably pretty transparent to the type of work that I think needs to be done. As far as saying we're going to look at medical travel, when I got elected in 2003, they were studying medical travel. When I die, they'll be studying medical travel, not hopefully because I die, but that said, I suspect it will be, as long as there's a government, they'll be studying medical travel. So to me, that does, specifics matter, and I think the public wishes to weigh in on that. So I've given you one example without trying to get too many. I could do 100, but that's the type of action detail I'm curious, and I think the public's curious what you're doing. Thank you.
I do want
Sorry. Mr. Florizone, go ahead.
Because of the public.
I'm so sorry, Mr. Chair. I jumped ahead, and I shouldn't have. So through you, I would just like to say that we're going to take a bit of a different look at medical travel. We're going to actually follow the patient through that journey. We're going to map their journey. We're going to document their journey. We're going to understand from the patient's point of view, not only statistically, but the narrative around their journey. We're going to take steps to avoid the journey where possible by providing appropriate care locally. And we're going to generate those ideas through the staff. Now, I know in the interest of time, you were very specific about ratios, so I'm going to turn to the CO to be able to speak to some of the reflection that we have here. But I also want to say that, you know, British Columbia is working on this, and we're watching very closely. So, Kim?
Mr. Riles.
Thank you, Mr. Chair, and thanks for the question from the committee. This is obviously a really important topic. There's only one place in our healthcare system that we actually have established staff to client ratios, and that's actually in long-term care. We have a funding formula that's used that allocates hours of direct care per client. But there's actually no other policy around staffing ratios. We have some that we have informal, or that we have formal and informal practices on. For example, in intensive care around ratios of nursing ventilated patients, et cetera. But there's no funding approach in the NWT that sets out established staff to patient ratios. I would say that this is something that we hear significant interest in, and it is something that, as the public administrator mentioned, we have a people strategy forthcoming based on the types of inputs such as this, where we've heard there is a priority. So I think at least advancing this as a question, that may be an appropriate place. Now, I will just, of course, emphasize that is very much in draft at this point, still a working document, and as the public administrator mentioned, would be presented publicly at the point that it's ready to be released.
Thank you. Mr. Florzone, you mentioned 52 improvements in your example of like small improvements that may pass or fail. Is that a hypothetical you're presenting to the committee, or is there an actual list of 52 improvements, Mr. Florzone?
Thank you, Mr. Chair. We haven't listed out the 52 because what I've done is I've challenged the system, the leadership, the administration, and the staff and medical association, the medical staff writ large, to come up with 52 ideas that we can test. So what I've done is set a notional push target around a change a week for 52 weeks. We haven't launched yet, but what I'm trying to do is gain an appeal and a support and an excitement around the ability for us to take ideas and put them into action.
Ms. Reid.
Thank you, Mr. Chair. I'm excited to read the report when it is made public today in full, if it's more extensive than your presentation, which I certainly would assume it would be. The two things I continue to hear from residents, from this committee, from practitioners, from people going through the health system is why do I bother to put in my feedback to the Office of Client Experience? Is that data going into a black hole? Is there ever going to be an Office of Practitioner Experience, which I think Emily Morgan has pressed on for some time now? So to me, it's great that this is laid out the way it is. It's very digestible, it's very clear and understandable, but for me, I want to understand how change will be driven by the feedback from people who are going through the system. And I think you touched about this a little bit on medical travel, which is good to hear, but also how it's going to be changed through practitioner. And you say that there's a people strategy coming momentarily in the next month or so. These are good things to hear. I think what we were expecting to hear, as Mr. Hawkins said earlier, is more detail and something we can point to where it's the experiences of people in the system, be they practitioner or client, are being heard and being acted upon. So I guess that's my question, Mr. Chair.
Minister, do you want to handle this?
Yes, and before I turn it over to the public administrator, one of the biggest pieces that was important that I felt that needed to be done was the town halls with the staff, and those were one piece that are so people who participated in that, we are creating an action plan to follow up with the staffs in each region on where we are and what to follow up with them. And taking those suggestions and opinions and their frustrations is part of how we are, the department is looking at the people strategy. So as well as taking all of the different things that we've received from, the Medical Association and building that into with what we can do without, being in breach of the collective agreement. So there are many things that we know that internal improvements can be, but I'll turn it over to Dan or Kim if they can have more specifics on that. Thank you.
Thank you, Madam Minister. Mr. Flores.
Thank you so much, Mr. Chair, and thank you for the question. I've set out the first of regular quarterly meetings with the regional wellness committees. They are, and these chairs and the going out there and meeting with people in the community and leadership in the community is really an important part of listening to that voice of the patient. So I just want to share with you what they told us collectively to be their top priorities, because I think this will really resonate with the committee. I think this is what you're hearing as well. At least I hope so. So what we're hearing is increased demand for mental health services and suicide supports, often related to the impact of hard drugs. There's a lot of worry of violence, of drug use, and the type and profile of drugs being used, not only in Yellowknife, but also throughout the territory. They talked about medical travel modernization and renewal, and there are many concerns that they're hearing from citizens throughout the territory around access, around understanding medical travel, around the need for travel, and the time that it takes. The need to assess and renew health infrastructure across all regions of the NWT, and while that's not part of our portfolio, it's obviously of great interest to this committee and to the legislature and government as a whole. Maintaining a regional voice in the governance structure is really important to them as well. And I got to say how impressed I am with the regional wellness councils and with the not only the chairs, but the people that I've met that are on the councils, their commitment to hearing the voice of the patient, of the client. They also talked about the impacts from elimination of the deficit. So they cautioned both government and the authority on not moving too quickly on cost cutting. What they wanted to see is a reprofiling of some of the savings from administration to investment in improving access and quality of care locally. So they wanted obviously to preserve jobs in the rural and remote, improve and maintain and improve services in rural and remote, and we certainly heard them. And then finally, recruitment and retention of health and social services professionals. Now, I mentioned this is just one aspect of the voice of the patient. We have other networks I'll maybe let Kim speak to if we have time.
Ms. Rose.
Thank you, Mr. Chair. We have had now 2 years with our Office of Client Experience. I think I was just trying to look in my email because but my computer's crashed. I just received our second year roll-up of the draft report of the inputs we received from that office, but I'm not able to pull it up. But certainly we've had a high amount of uptake of using that service. I understand we continue to try to figure out ways to make sure the information for how to access that is out there, because still lots of people that we're hearing are unfamiliar with this service and with this support to be able to help them to navigate their health and social service needs. But we certainly have seen some themes emerge. Medical travel obviously is one that consistently comes up, as well as other navigation and access issues. So that information does get fed back. And I believe I met with, I'm not sure if it's this committee or another committee, probably almost a year ago, where we had talked about the opportunities we're taking to try to actually fix system issues instead of fix fixing the same issue for individuals 100 times, try to actually move the system a bit so that it alleviates some of those needs for supports and navigations. So that work is still very much underway. We have now, like I said, just hot off the press, we'll be having 2 years of data available to us to support and continue to be able to make refinements. But I know that the member spoke about medical travel and how it will be the perpetual issue of study, and I don't disagree. It's certainly a challenging, multifactored topic that we continue to try to chip away at concerns and challenges that arise, and certainly we're eager to participate in the modernization work that's being led by the minister.
Thank you. Mr. Florzan, do you have access to those reports, the Office of Client? Okay, let's just confirm that on the record.
Yeah, Mr. Chair, I haven't seen them yet, and usually the cycle is much like the authority. The CO would receive and meet with her team, gain clarification, finalize, and then the following opportunity, they'd be presented to me. So I do have that opportunity, and then I turn around and present it to the minister. Hopefully that all happens within a very short period of time, but this is the method that we're using. Yeah.
Thank you. Ms. Morgan.
Thank you, Mr. Chair. And thank you to all for coming in and talking with us and the public today. My first question is for the public administrator. So what role do you have, I didn't see it in the work plan per se, but in reviewing the management at the health authority? I know that, that's something that you kind of have a unique opportunity to do in a way that obviously MLAs, politicians, we can't, do sort of job reviews or look into management that way. And it also can't be done by, say, an independent consultant who, again, can give their recommendations from the outside, but can't get involved in sort of supervision or management of staff. And so, for example, 360 reviews. I think a number of years ago, there was some sort of practice that managers within the health authority would have to go through a sort of 360 review and get feedback from all those around them to be able to improve performance. So what role do you have in reviewing the performance of management at the health authority and holding people to account? Thank you.
Mr. Florzan.
Thank you, Mr. Chair, and thank you for the question. My interest and my role is to understand the process, the policy, and the procedure. So what I want through the CO is some assurance that there is a methodology in place that satisfies the accountabilities that are in place. My sole employee is the CO, but ultimately my expectation would be for her to in turn have a system of review that cascades throughout the organization, doing exactly what you describe. Now, 360 evaluations are one methodology. We haven't gotten into and my role is also the structure. So I'll be working very closely with the Chief Executive Officer to define the new and ongoing structure. This will be done in the latter part of the year, early into next year, where we really start to delve into how we need to be organized. It will be part of next year's administrative plan. A lot of what you see, by the way, in this plan is about this year. It's front-end loaded. And what I want to do is return to the committee, if I should have the opportunity and privilege to have a renewed contract for a second year, to give you more detail on year 2 of the plan. But I'll turn to Kim to talk about management evaluation and the approaches that we take currently, which are consistent with government, and how she's starting to think about that evaluation into the future. So, Kim?
Thank you. Thank you, Mr.
Go ahead. Your mic's on.
My light came on, yes.
Just short, so they have another opportunity for another question.
Yeah, so I'll be very short. So we use the established GNWT competency-based performance evaluation process. It's based on objectives. So historically, the Leadership Council would approve my objectives for the year, which were aligned with the operating plan, which aligns with the GNWT, or with the department system plan. Then each executive is assigned a set of lead objectives. Their performance is measured against that and reported. And the Leadership Council historically historically, would review my rolled-up performance on the objectives that were set at the beginning of the year. And then, and so for this year, we'll be undergoing that type of process, presumably, with the public administrator, seeing as I don't have a leadership council anymore. Going forward, the performance objectives for myself and for our executive team will roll in large part from this plan that the public administrators assembled. It'll be reflected in the organization's operating plan as well. So that's kind of the short framework on how we do that. 360s we use, it's a contract you have to access through the Council of Health Leaders, the Canadian Council of Health Leaders. We do have a contract available. We tend to use them episodically. I specifically, personally use them with people that I have concerns and I feel like they have a need for growth. So we use them in a targeted way as they're not part of the formal process here in the GNWT, and they're very expensive. So that's the current short answer.
Briefly, Madam Minister.
Yes, and I know. And the public administrator, we and him have had many conversations to ensure that, you know, we talk about the executive and the senior management and where the direction is going down, but it's the front line. It's our frontline staff and how making sure that, you know, that the people that are serving them are being measured on, you know, the things that are tangible that can make change, and if there's things that need to be supported with them, that we are looking at ways to support managers to support their staff, you know, so just making sure that staff are aware that they should be using the processes to, you know, to bring forward to their managers so that they're aware. Thank you.
Thank you, Madam Minister. Ms. Morgan, I'll put you back on the list. We'll now go to Mr. Morse.
Thank you. First question, very quickly, yes or no answer. Mr. Florzone, did you tune into our most recent briefing with the NWT Medical Association where they shared significant concerns and communicated their concern that the system continues to verge on collapse?
Mr. Florzone.
Yes, I did.
Mr. Morse.
Thank you. So knowing that, you're well aware of everything they shared with us. And so it's good to hear you saying that ideas from practitioners are being solicited, implemented quickly. I guess the question becomes, for me, why do we continue to hear from practitioners that they feel they're not being listened to and that the system is not responding to their concerns? Have things completely changed in the 2 weeks since that briefing? And why is there still such a disconnect between what I'm hearing from administration and what I'm hearing from on-the-ground workers? Thanks.
It's a mystery to me. And the reason I say that, and I don't mean to be flippant, but I want to say that I've been meeting on a regular basis with the association. These matters have been raised. There's an open opportunity to raise the matters with administration present. I do want to acknowledge that there are real issues that the association is raising, but the disconnect when we have an opportunity to connect one-to-one, connect and work through these problems, the good news is we've established that on a monthly basis. I'd like to think that a lot has changed in 2 weeks. But hearing and seeing the recording, because we watched it several times to try and understand what the issues are, we're unpacking it as we speak. I continue to reach out to the association, and my messaging is this, that we can make improvements. We just need to work together to achieve those.
Mr. Morse.
Thank you. And so just based on the urgency of the messages that I've been hearing and the urgency that we've been hearing from workers on the ground for quite a number of years now at this point, I look at the two actions in your work plan related to improving stability of the health and social services workforce. And the two actions in summary are a people strategy, which may start to get to some of these issues, and enhancing efforts to ensure the workforce is representative of the population. So those are nice high-level goals, but I was perhaps expecting to see us addressing the immediate crisis that practitioners are telling us that we're in. And I think the public is rightfully quite concerned about hearing stories that the ER is potentially on the verge of not being able to be open all the time, that we have so few doctors left in the system that we can't effectively run the system in responding to emergencies. So considering that, why are we not being more urgent in our messaging in terms of triaging problems and getting at the most immediate concerns in the system, as opposed to working towards things that I think would be better characterized as nice to haves once the system is stabilized? Can you maybe speak more to the immediate concerns we've been hearing? Thank you.
Minister Semler.
First, I just want to address, and I've heard it from residents now, that as a healthcare professional, I think it's, and I'm trying to be, and I've heard, and I've been hearing from members in Yellowknife, and most recently as yesterday, that statements like that put the fear in our residents. I've heard from Indigenous leadership that have said, what is going on? And that is not fair to our staff that are working. And yes, I understand that in a system that we are, that there are many levels, and that we've shared with, with members, and we can provide more detail of what those backup plans are always, in a sense that if there was ever, a shortage or reduction in emergency room physicians, and I think the thing is that place the doors will never close. So I want the public to be clear that those doors will never be closed, and there will be support. And there are many contingency plans to do that. And if we need to get into those details, we can provide those, at a later time, so we don't take up the time. So I just want to make sure that the public knows that, because that is unfair to the people who are very ill and are worried, and it's causing more harm on them to be scared and in fear when we know that the doors are not going to be closed. So and then I'll turn it over to Dan. Thank you, Mr. Chair.
Thank you, Madam Minister. Mr. Florazon.
Thank you very much, Mr. Chair, and thank you for the question. I do want to say that the Medical Staff Association and our team, including leadership, are very well aligned. They've presented to us 3 top priorities that we support them on. One is interest-based bargaining. So they're obviously the bargaining unit for physicians. We're interested in being at the table to share our interests as well. The perspective of the patients, of the staff in general. The second is incentives to be able to recruit and retain. We're absolutely committed to seeing what can be done and working with the department and Department of Finance to see those incentives put into place. The third are enabling technologies, and this is where we get into virtual care and AI, and we're keenly interested in working with the medical staff on those fronts. So when I said the 52 improvements in 52 weeks, this is what we came up with through conversations with the association. They have been very positive meetings. When I say it was a mystery, I didn't mean to sound flippant. I know it sounded like that. But we've been working in what I view as a very effective relationship with the medical staff. We need to work with all medical staff, not just the association. We need to work with groups other than just physicians, with teams of providers. And when I think about the emergency department, it's not just emergency room physicians, they're critical, but we also have a whole team of specialists that support that emergency department, as well as nurses. We have other health professionals that support that emergency department. So when I say the Stanton has no risk of closure, I'm not trying to have wishful thinking. Is that we will do everything within our power to avoid a closure that could ever happen to a place like Stanton. Even during evacuation, we kept the emergency department going. So I thank you for your question, and Mr. Chair, I just want to say I'm highly committed to working with the medical staff. They're key to our success.
Thank you, Mr. Florazon. So just noting that point, the NWT Medical Association released a press release after you made your media presentation on the Emergency Department locum contract that rebutted some of your messaging there and clarified some points. So when you say it's a mystery, I think that's something that the public and this committee takes note of, that there seems to be a disconnect there. So do you have any comments on why that occurred? Why there are statements in the media rather than at a table when you're talking to one another to clarify these things? Mr. Florazone.
You're asking me, Mr. Chair, to speculate on why it appears there's a disconnect. I can tell you there's no disconnect. So it might be worth a follow-up. If there is, I need to know.
I'll leave that with you, Mr. Florazone. And just for the record, this committee welcomes any correspondence, concerns from staff, healthcare professionals, the Medical Association, if they have an emergent concern around any aspect of the healthcare system. And we welcome those so we can have the conversation internally, we can have the conversation with them, and we can have the conversation with you. So I don't think it was, speaking as a member of the committee, a fear-mongering exercise, but much rather a urgent appeal that now we're seeing some concrete measures taking place. So we certainly welcome those concerns and look for productive ways to address them. Ms. Whalen Armstrong.
Thank you. Thank you, Mr. Chair. I just want to say that I'm very grateful, thankful, with the four priorities that's outlined. Coming from a small communities, there's a lot of us that represents regional MLAs, and for a long time we feel like small communities were forgotten. Nobody listens to us, So I am very grateful, thankful that, Minister is from a region where she's surrounded by small communities that have, is going through the same experience as all these other small communities with limited access to health care. There's a lot of improvement that needs to be made. We know that, we are aware of that. So, and especially, being a frontline worker as a nurse, so really well. So, as a minister or as a nurse too, and so you are aware of the situation. And what I see here, the four priorities, there's a lot of small communities that are mentioned. So I feel like, the system is listening to the small communities, to the people in small communities. Working with the people, even I can hear it in his voice, where I thought I heard some elder's voice in there working together. How can we fix this? And I know that the department is doing their best to improve the system. It's not just for the regional larger center, but the small communities. So if we can get to the small communities, then it's going to be less pressure for a larger regional center, and streamlining the medical travel, and so documenting, mapping, the patient care, and that is really greatly needed in many of our communities, because lately our people have been, we have high rate of diabetes. There's a lot of lately, there's been a lot of our constituents needing dialysis care. There's high rates of STIs. I'm just, saying that the social issues due to the drug crisis that, Dene Nation just recently had a meeting about that. But one thing that the people are not talking about, or the leaders are not talking about, not here too, but, out there, public health nurse, we need more of public health nurses in small communities due to the drug crisis, because what I've been hearing from my constituents and other people is that a lot of our young people to meet their needs, there's a lot of sexual exploitation happening, prostituting. Young boys, young girls, young kids as 10 years old are experimenting with the crack cocaine now. So it's a real crisis. We need more of public health nurses. So I just want to ask the minister if the department is working with the indigenous government and other organizations in small communities, like Friendship Center, because they are the one that are, where the Friendship Center exists, they see a lot of these clients. Even in Bichiko alone, in Klitschko region, we only have one, and then there's the Klitschko government too. So I just want to know if the department is working with the indigenous government, not just only in Klitschko region, but in other regions, because the drug crisis is a major issue. And if we don't, a lot of people are concerned. And with the high rates of STI, there's other stuff too, HIV, like we need to let the public know about, because we do care about our young people. We do love our young people because they are our future generations. And if we ignore it, then a whole generation of our youth is going to be, gone, or like we're going to miss. They're the workforce too. So I just wanted to ask the minister that. Thank you.
Madam Minister.
Thank you, Mr. Chair. Mr. Chair, what I can say is that, and I first, my condolences to the TCSA, to the people of the Klitschko region, and to the family of the past Chair Ted Blondin, that our public administrator was fortunate enough to be able to get and meet and hear and learn from Mr. Blondin and Chair Blondin. And so that even though he's over the NTHSSA, there's a lot of work that overlaps within the NTHSSA and with Hay River and Klitschko Service Agency. But what I can say is that Klitschko Service Agency is very well aligned with the Klitschko government and their priorities and how they provide services. And so what I can say is I know that they're taking part in the model of care of health in the health centers, the small community work, and that they are looking at a model and role for public health nurses. That's that's just they're looking in this. And so because of the need, we've heard with public health issues, that is a priority to work with all of the tools that we have to be able to support them with all of the many things that you have said. So we are collaborating and supporting, and they are leading in the work in the Klitschko.
Mr. Flores.
I just wanted to add my condolences to you, to the community on Ted's passing. We had the opportunity to spend several hours with him, and Kim and I, the two of us, agreed on the way home that we witnessed history. We had the privilege of meeting someone with such wisdom and a rich contribution to First Nations, to the Dene Nation, so if it sounds like you hear in our voice, I consider him in just a 2-hour session a teacher. So I wanted to express our condolences to you. I did travel again to Bichiko and had a chance to pay my respects, but there's no conveying it in a meaningful way what an impact he had on us in a very short period of time.
Ms. Yakalaya, the floor is yours.
Thank you, and thank you for the presentation. I wanted to comment on, I appreciate we're in a time of instant gratification. Everybody wants things done, not yesterday, but today. And having said that, I know process takes time. And going through a lot of what you're dealing with is a big undertaking. However, you mentioned in your presentation health cabins in the, and you did visit Jean Marie's health cabin. Can you tell me a bit about your experience there? Thank you.
Mr. Florzo.
Thank you, Mr. Chair, and thank you for the question. What was really important to me is to go and see, and Kim and I felt really, her experience obviously goes deep with that region and that area. As we went, we traveled across the ice road, we traveled down the road. We got a sense from a community member who's so passionate and works there and delivers services every day. We saw the cabin, the physical structure. We saw the technology and its limitation. We also heard very deeply that some things have changed, and it was confusing why they had changed, not only for the individual that works there, but for us as well, to understand how, under the auspices of a new standard, somehow certain things couldn't continue to be done. And what I really appreciated was Kim, and I'm referring to our CEO. Kimberly had made some observations that I think only a nurse practitioner and a person with that kind of rich background could make, about the need for us to start really reframing things from a patient point of view. If you're living in this community, and this individual who's a member of the community is delivering services to you, and we're trying to impose some type of top-down standard, we really have to ask the question, what are we trying to achieve? What problem are we trying to solve here? So I think it was an eye-opener, and what we saw were opportunities. We talked about the space. We talked about infrastructure. We had someone from the Department of Health who was with us on that travel, who showed us some of the health cabin plans that had been put together for other communities. But what it really inspired is the need to go to 6 communities in the Dehcho. And I mentioned we wanted a demonstration project. What we want to do is go to those 6 communities and start and make them the beginning of the road, not the end of the road. Start asking them and traveling with them down the road to get a sense of, if you have diabetes or multiple chronic illness, how do you gain care? Even on the extreme side, if you're in crisis or emergency, how do you get access? How does this sole individual in the community manage the complexity of what could happen in a crisis? So it begged any number of questions. I have to say this, seeing the health cabin for Kim and I won't speak for Kim, but it really centered me on what was important. The minister had conveyed it to me, but she said, go and see. I went and saw with my own eyes, and I thought, we need to do something here. This is inequity to the nth degree. This shouldn't be happening in Canada. What we ought to be doing is delivering a quality and a standard of care that's far different. And in spite of all of the constraints, the wonderful staff member who was delivering services each and every day, she wasn't even taking holidays, trying to accommodate, or it's at least staying close to the community so she could accommodate the community needs. That deep commitment was there. So sorry to make it a little more emotional, but it was a really eye-opening experience. We're going back. And we're going to go back and we're going to start to collect data. We're going to feed the bureaucratic need to collect information. We're going to have our Indigenous advisors travel with patients to be able to capture their narrative, their story. And we're going to work the improvements. So the 52 improvements out there are going to start at those health cabins and communities that have nothing. They don't even have a health cabin. So we're going to start in the Dehcho. It's a demonstration, but we're going everywhere. We're going across the NWT. It just seemed to be the right region to get started in.
Ms. Ross.
Oh, thank you, Mr. Chair. I'm not sure what I can add because that was a great summary, I think, of our visit to Jean Marie. To Jean Marie River, but I think the member for the question, because I know that she has community of Kikisa in her riding, and that community has its particular challenges with regard to how health services are or aren't available. And I would just maybe quickly say, as somebody, I lived in the Dehcho in Fort Simpson, Lid Lake for 10 years, and so for me, it's really wonderful to have this attention and will to try to increase the standard of care in those smallest communities. Because, I mean, I was a nurse for 10 years, taking the phone calls from those small communities, from these community health workers with such limited access to anything to help the people that they were trying to take care of. So I'm really excited to be able to do this work and to be able to try to perhaps at least start to close those inequity gaps. So excited to do this.
Thank you, Ms. Riles. We'll now turn to Ms. Morgan.
Great. Thank you, Mr. Chair. I wanted to ask, this is something that I've raised in the past, and I'm not sure where it's at, but one thing that I think could go a long ways to better sort of compensating and recognizing the work that staff are doing is if we could have a better scaling system or way of, so it's the way that job descriptions are scaled and then the way that pay is accorded to that. So I wonder if any progress has been made or if the Minister or Public Administrator could commit to reviewing or changing the way job descriptions are scored so that the actual level of risk and responsibility that staff are taking is appropriately compensated. I mean, we see, managers and other levels of the government who most people would recognize are not taking on nearly the level of risk and responsibility that, say, frontline nurses are, but that the frontline workers are getting paid much less. So there seems to be a mismatch there. So can the Minister or Public Administrator comment on what's being done in that regard? Thank you.
Madam Minister.
And thank you for that question. And I think, yes, this is not the first time it's been raised. And understanding, this is something that doesn't fall under my authority as the minister. It is, under the HR portfolio, under health, or under finance. But we, and I think this is the thing is that where we are now, we know that we've heard from staff, we've heard this time and time again. Myself being a nurse, I've felt this, and so what I can say is that there is work that I have been working along and seeing what are the ways that we can collaborate with and with finance. But I'll turn it over to Dan because he's got some stuff that he's been tasked to do too. So.
Mr. Floresville.
Any good cascade is now to turn it over to Kim, who's, this actually is a topic that, and I'm so thankful for the question. This is a topic that was raised just in the last couple of days as being key in the people strategy. A need to really deal with those internal equities around position and position ratings. We talked about all kinds of professionals. We talked about nurses. But I'm going to turn it to Kim just to speak to a bit about what we discussed and where we're kind of headed.
Ms. Riles.
Thank you, Mr. Floresville. Thank you, Mr. Chair. I perhaps just to keep it brief, I would point to the last action in the Public Administrator Plan. I think it's the last or second last, where advancing recommendations to the minister around shared services as they relate to, this one would be specifically HR. And then, as Mr. Floresville already stated, there is a people strategy. And in the past, there have been at least one large scale in my 25 years undertaking of a health jobs review that looked at all job descriptions, and then there have been some more focused ones that have happened over the years as well. So that would potentially, as was mentioned, be something that could find its way into the people strategy.
Okay. Thank you, Ms. Morgan. Oh, sorry, Mr. Floresville.
Thank you, Mr. Chair. So I do want to say, just so that it's really crystal clear, what we're advocating for is a review of the review process. So we got this methodology that's used. I won't reference it specifically, but it's used and it's quite common in governments. We're saying, for the health sector, maybe we need a different approach. Now, I'm not trying to signal anything, and I'm not a step necessarily with the conversations with government. I want to make sure that I'm in step, but we'll be using our people strategy as a way of trying to encourage a new evaluative approach to job descriptions. We see this as a real issue. We share that issue with you. And it comes from staff. That's what we've been hearing. Thank you.
Ms. Morgan.
Thank you, Mr. Chair. And I know there's been a lot of talk about how the importance of different departments and different ministers working together on health issues, whether it's finance, the Premier's office, and health, and HSS. And I think this is one example that may be a good test when it comes to HR issues. It's like, this is where we really need you to work together, and an example of where we need to see results here. I just wanted to follow up on a few comments that were made earlier in the briefing, because I do think we need to keep going back and focusing above all on staff retention, even more than recruitment, because if we can't retain, then we get nowhere. But my concern that keeps coming up is that we keep taking for granted the work of frontline practitioners. I mean, ever since COVID, we all like to talk a lot about how healthcare workers are heroes and they do amazing work and the sacrifices they make. And, there was an example given a few minutes ago of this community health nurse in a health cabin who doesn't even take vacation. And we all kind of applaud and say, what a hero. And you mentioned that, we kept the hospital open during the evacuation. I mean, I would push back on that and say, it wasn't you personally. I know you were speaking about the authority as a whole, but that was a few frontline practitioners who stepped in and kept the hospital open. A few frontline leaders who made that happen despite the systemic failures that were happening. And we have frontline workers who are, working and making incredible sacrifices despite the systemic failures around them. And so if we keep I understand there's a tension between we don't want to alarm the public and we want to reassure everyone that everything's fine, but if we also just keep taking for granted that frontline practitioners will push themselves further and further and further to make sure everything's fine and the public never sees anything is wrong, then people are at their breaking points. And so what I want to see in these strategies and in the actions being taken first and foremost is that we stop sort of assuming that staff will always just take up the extra load. They'll take those extra shifts. They'll not take their vacations. They'll come through. Don't worry. Like, our systems will keep on rolling. And if we don't assume that and actually do take their sort of desperate pleas for help seriously, I think just above all, in all of our messaging and actions, we just absolutely need to stop taking frontline workers for granted. So that's more of a soapbox, but I'll let you respond if you want. Thank you.
Well, I'll very briefly, okay, because we're already over time for that. I don't want to, I've got a list of members, so very, very brief, Minister. Go ahead.
Yep, no, and I want to say that, this is, and I'll say, I've never been the minister that said this place is perfect. But what, and what you're saying, that is the immediate action that, and that's why we've made decisions that some people may have been not appreciative, and things like that, because we need quick movements and we need things. So we have the public administrator in place. He's got a daunting task ahead of him to help support staff. Under the Premier, there's a health sustainability, and our minister, all of our ministers know that there are things. Because every one of them have either patients or healthcare staff that are their constituents. So we've all heard it, and we know the urgency that we need to start to find tools to support them. And I'm not saying that we weren't doing that before, but we have bumped it up. And so I just want to ensure that we're not sitting here going, like this is not the conversations that we're having outside of this room. There is a lot of stress and pressure and, staff that are pushing and pushing and pushing to try and do these things that we need to do in order to improve, the workplace for our staff, which provides better care for our patients. So as short as I could there.
Very briefly, Mr. Floresville.
I take your point. We have taken for granted the fact that our physicians, our staff step up. And what I don't ever want to say when we say the emergency room will not close, the reason why we have staffing this weekend in that emergency department is because of the goodwill of the emergency room doctors and the staff who have canceled their plans, who have adjusted, and we continue to do this time and time again, is have them adjust their plans to be able to accommodate our ability to maintain service. I don't want to ever leave the impression with the public or this committee that we take that for granted. We can't take that for granted. In fact, we've got to show them our goodwill to do something about it so that next summer isn't worse than this summer. And I can tell you that this summer and this period is worse than we've ever experienced. So I want the public to understand that. They need to know that. And I want to acknowledge that. But we're going to work really hard to make sure that every day we get a bit better. And we're going to continue to do that. We'll strive towards it.
Thank you. Mr. Hawkins.
Thank you, Mr. Chairman. Mr. Chairman, I do have an appointment with the Housing Minister at Aspen. I've been asking for it, so this will be my last round. I have to sneak off, so I say in front my regrets. I'd like to stay to the end, but sometimes we have to balance things, as everyone knows. So I just want to point out something here very interesting. I'm glad to hear other people are interested in retention. I brought it up during the last session about how important it is. I'm not a contract HR expert, but I would say I would be surprised in any form as to breach a contract when you give someone more in a positive way. In other words, more shift in premiums, more pay, more days off, more training. I yet to find anyone say, no, you're breaching the contracts by giving us better things. So I always feel uncomfortable when it quickly spirals to the thing about how we have to go back to the process and whatnot. I can see other people not happy, but also we have to take a stand somewhere, and I think that's fundamentally one of the challenges here is, what are we taking a stand on? And so we hear a lot of platitudes, and I like them. Don't get me wrong. We want to do better, we want to stabilize, we want to do these things, but that's why I was curious about the examples. So if I might say, and it's my time per se, in the sense for the clock, but I'm going to give an example of urgency, and it's strictly urgency example, so don't get caught up on it, because I'm going to bring it back to the healthcare system. So we have a boat. The boat's out in the water, away from shore. The boat is now sinking. But at the same time, dinner was being served late, and some light bulbs were dim, not broken. So the question is what's your priority? Obviously, you would think stabilizing the boat would make the most sense. Now, our healthcare czar has 5 months on the job, from my understanding. He has decades of experience on these types of files. I'm not here to school him on his talents. I believe he was probably hired based on them, so I'm not going to get into that. But what I'd say is there must be priorities to ask ourselves, how do we respond urgently to urgent situations? The example is to point out, I don't care about the dim light bulbs. We may have other issues. We have doctors saying emergency may close. We have other types of things. That's just one example. It may not be the example, but we have many things that are striking examples of things that should be perceived as absolutely urgent. And so that's really my concern is, why don't we show the public we're focusing in on some urgent things, and we're certainly focusing on longer strategy things, and these are the things publicly told to the public. And the last thing, Mr. Chairman, just noting the time, because I can see this answer potentially being fast or long. Our healthcare czar has visited a number of communities. Thank you for listing them. I would like your schedule public. I would like to know how many days you've been here in the north, and your schedule in the sense of both behind us and forward, so people can see where you're going and who you're speaking to. And frankly, this is not a personal direction at you, but feeling someone's come from the south to solve all our problems, who's operating and managing from the south, just doesn't sit well with people. May not bother some academic type, but when you're in the grocery store talking about somebody who's managing this problem from Regina, it's awful tough to carry the weight of that. I'm prepared to. I'm willing to say, hey, this might have been the best person and we're going to give them a chance. I'm willing to wear that. But at the same token is, there's a sense of feeling you really are engaging personally in these areas of territory. So that would really matter to people. And again, I'm prepared to defend your location where you're hired for and where you may need to work. But I think at the same time, there's a balance. People need to see you're here, where you're here, who you're meeting with, those types of things. And I don't think that that should be treated secret in any form. And as a matter of fact, I think we'd be doing everyone a good service, the department, the authorities, et cetera, including the communities, that transparency. Thank you.
Thank you. Minister.
Yes, first of all, what I would like to say is that Mr. Florazone has been hired as the public administrator. The term czar has not been in his job description, so I think I would like to clarify that. So he is the public administrator of the NTHSSA. Second of all, there is, as a health minister, I live outside of the capital. So does that mean that I have to move to Yellowknife? Do I have to be in Yellowknife all the time? Mr. Florazone is here, he's in Fort Smith, he's in Betchico, he's in many other areas of the Northwest Territories. He's scheduled to be in Sahtu eventually, up in the Beaufort Delta. And his office is here downtown in the NTHSSA Executive Office. There are many things that, we are doing, and I think to ensure that the work is being done will show in the communities. And when you want to talk about what's prioritizing, I'm sitting, and I'm sitting in this room, and the priority that we have seen across the Northwest Territories is starting in those health cabins that have nothing. Thank you.
Thank you. You may go, Mr. Hawkins, but the member asked for 2 points of information, and you're welcome not to volunteer these, but one was a schedule, a disclosed schedule of the public administrator's planned travel to communities, and how many days the public administrator has been in the Northwest Territories. Is that available to committee, Minister?
We will present the information that I have, like the committee travel, the community travel, and we can discuss this further in camera, as this is something that we don't discuss, staffing issues. If we have, people within the government that are working remotely, we don't talk about certain things. We don't talk about contract obligations in public. Thank you, Mr. Chair.
Thank you, Madam Minister. We'll now go to Ms. Reid.
Thank you, Mr. Chair. This question is for the PA. In your opening comments, you spoke about a need to have space to implement, and in your presentation and in some of your answers to committee, you've said we're already implementing. So can we perhaps be a little bit more explicit about what space is needed and what we're already implementing? Thank you, Mr. Chair.
Mr. Florazone.
Thank you for the question. In the past 3 weeks, I spent 2 weeks just firefighting. And that firefighting was based on media, conjecture, things that were stated. The space that I'm asking for, Mr. Chair, is the space to be able to actually get some stuff done. Again, it's not that democracy and the need for public input and scrutiny and accountability aren't important. These are fundamental to this government. But I also need some time to actually get some things done. And so the space I'm asking for is to cut a bit of the, give me a bit more rope so that I can actually go out there and do some things. Hold me accountable for what I've done. Rather than having me to respond to issues that may or may not be top-ranked issues. Now, who determines that? Not sure, but obviously the public will dictate what is the top priority. Some examples are if you bring a negotiating group into this committee to present their negotiating stance, then you have to expect they're going to raise issues around negotiations. There's not much I can do about that except for exercising what I have by way of authority and accountability that's been conferred through this government, through this minister, through the legislation. So being held to account for things I have zero control over is just a deep frustration. So I don't control negotiations. I don't control health human resources to the same extent that I would in the South. I don't control IT, right down to phone systems and scheduling systems. I don't control privacy and privacy issues. I Obviously, we'll advocate and work with administration to get these things done. Give me a little bit of time and then allow me to respond and be criticized to the actions that I've taken. The time is limited, and I'm just getting a little bit nervous about my ability to action things. Summer's coming, fire season is there. We're seeing, this could play out to be a very difficult time, and just holding on to the day-to-day operations is going to be challenge enough. So that's what I meant by having this space.
Thank you, Mr. Chair. And returning to my question, it was two parts, so I'll reiterate the second part. Thank you for that. You also spoke a bit about we're actively implementing what's maybe the low-hanging fruit that you've been hearing feedback on. Could the minister and the PA be more explicit about what is already being implemented? What's not necessarily a laundry list, but being more specific about what they've heard and what they are actually actively implementing on what they've heard. Thank you, Mr. Chair.
Madam Minister.
What I'm going to do is I'm going to turn it over to the CEO, because these are operational things that are being implemented, and she's the best person to be able to speak with. I give the direction to the PA oversees and gives the direction to the CEO, and she's got the expertise to answer this question.
Ms. Riles.
Thank you, Mr. Chair, and thanks for the question. I guess I'll maybe give one example that directly flows from the work plan. So as the public administrator shared, we were in Jean Marie recently in the Decho, and this really framed up the action that you're seeing in here, the commitment around service delivery in cabin communities and what that exactly looks like. So we met with the Regional Wellness Council. The public administrator had the opportunity to talk through his vision on this. The chair of there was a chair there from small communities who were able to hear and talk about that with us. The local chief attended, the MLA was there. So we talked through what we thought about that. And since we've returned from that visit, even though this is still not officially even launched, that happens today, we've been working to actually gather all the medical travel data from a couple of small communities to actually look at how many travels have happened. We've been looking at the air ambulance data from those communities to be able to start to quantify the reasons why, so that we can then do kind of that deeper dive into like the reasons that people are moving in and out of the communities, where they're going, etc. We started meeting with the regional manager out in the Decho to talk about those communities. We're inventorying. We have people going out to inventory the equipment, the supplies, how they store them, so the technology, et cetera. So those are kind of the tangible things that we're already starting to get going to actually implement some of the work that you're seeing in this plan, and that's just one example that I can share some details of.
Thank you, Ms. Riles. Now we'll go to Mr. Morse.
Thank you, Mr. Chair. I'm going to try to be quick. First one is, they're both suggestions. Maybe if you could just affirm or confirm them. The first one is, I think it would be really helpful for us. I think that it's pretty clear that, communications is really important as we address some of these issues, communications with us, communications with staff. I think it would be very helpful if you could share relatively frequent updates with MLAs on actions to address the most immediate issues facing our healthcare system, particularly with staff, with confirmation included from the NWT and Nurses Local 11 that their concerns and feedback have been included when you give those communications. Is that something that you think you can provide us?
Ms. Minister.
Yeah. I will leave and I think the thing is that when nurses, I'm not going to get involved and talk about unions here. Though they have their own process that they will use, and if the nurses local union representing them will speak on their behalf of what their issues are, and I think what I can say is, with Kim and Dan can probably to speak to some of the high level levels of concerns that group brings forward, but to make sure that the public understands that that is the only group in the Northwest Territories that represents specifically just nurses and our nurses. So there, and then in the rest of the territory, the locals are not made up of, you know, if there is a nurse even on, I couldn't speak to that. So we are getting, you know, that would be a focus group that is here in Stanton and represents Stanton. They don't even represent the region. So, you know, there is, there will be a need to understand that. So getting the perspective of one hospital. And then also, you know, the public administrator, you know, has engaged with other stakeholders. But again, what we're asking is time for him to actually being able to dig in and do some work before he is reporting. Like, the work has to be quantified before we, and as the minister, yes, I've been in here for a year and a half, and everybody has been, you know, has been busy, and it's not the fact that they're, you know, like we heard yesterday from residents in this capital, there are tangible things that seem like they're easy fixes, and as I said, like a phone system alone is a computer that needs services, and when we built the, you know, infrastructure, these services, they don't meet the needs of what we're seeing now. So there is always things that we are problem solving in the back end that, yes, and I've also said this to my staff, that we need to be able to have some kind of quarterly update of tangible things that we are sharing with MLAs, because MLAs need to be reporting back to their constituents, I as well, that we are doing some stuff. So I will commit to ensuring, and what we share, we can work that out.
Thank you. Yeah, I was just suggesting including the NWTMA just to try and get at this disconnect issue. Like, if we're kind of bringing in that confirmation, I think it just helps tie in that that staff are feeling like their thoughts are being included. The other one I want to get at, it's maybe a little bit of a touchy issue, but I've heard from a few different people, a number of different people at different levels within the organization, that they'd really appreciate the opportunity to talk to the public administrator without their immediate supervisors or managers in the room, so they can just have a frank discussion about what they're experiencing in the system. I'm just wondering if the administrator would commit to doing that. Thank you.
Thank you. And just for the record, committee has heard that you're meeting, that the public administrator is meeting monthly with the NWT Medical Association. So, Mr. Florazone?
Yeah, thank you. Just further to communication, the minister has requested that I provide a quarterly report. We're going to be starting that up sometime soon. That quarterly report will be shared broadly and shared with this committee. Very pleased to put out not only some measures, but actions that have been taken. So excellent point. In terms of meeting, one of the things that I've been reluctant to do, and it's a bit of, well, it comes from experience, is anyone that wants to meet about someone without someone, unless it's ethical or legal or, you know, it's some type of significant breach, what I want to do is encourage people to speak the truth in front of others. And I will facilitate, and I'll make sure that we have a safe environment for people to raise issues. But there seems to be a constant in everywhere I go that people want to meet separate and have conversations separate. Now, I do acknowledge that there may be situations where that is appropriate, but when it's just simply to complain about not doing something, I mean, what do you expect me to do about that, except to bring the person in and to be really crystal clear? So it's really the rules of natural justice that I'm following there. Is nothing about you without you.
Thank you, Mr. Florazone. And I think we should all be very mindful of what the underlying issue is there, because that's not just in your workplace, or sorry, in the health system, that's across the board. People do not want to speak candidly or publicly in this territory, and it's a problem we have to solve and find better ways to solve it than just not doing it. Ms. Yakalaya will conclude questions with you, and then we'll go to the minister for closing comments. Ms. Yakalaya.
Thank you. I'm going to get back to the health cabins again. people in the smaller communities, as you're aware, because of your trip to Jean Marie and Kim's experience with small community that have health cabins, people need, they might need immediate access to care or access to care or practitioners, but they don't have the funds to travel to the regional centers, or they don't have even a ride to get to the regional centers from the community, say if it's an elder or somebody that doesn't drive. Those kinds of things are, I don't know, I wouldn't say if they're overlooked, but they're thought about. And how does that fall onto the health worker in the community? Do they fill out a medical travel form so the person can go, say, from Jean Marie to Fort Simpson or from Jean Marie to Hay River? And who covers that cost? Because in regional centers, we can just walk to the health center or drive to the hospital. And but the people that are living in these small communities, they don't have readily access to it. And yeah, so that was my one question. People keep asking me, talking to me about that. It's just like people not having any grocery stores in their community. They have to access grocery. They need food to eat too, so they have to drive out sometimes 60 kilometers or 70 kilometers to the next community to get food, or remote communities, they have to fly in or fly out. And so it's very costly. And is that going to be put in your recommendation for medical travel? Thank you.
Madam Minister?
I think what you identified there was how I explained that to the public administrator before I asked him to go out to the communities. And it's because of MLAs raising these issues in the small communities and my experience in some other regionals, areas that we do have different ways that we're providing services across the territory differently. And so there is an inequity even in our smallest health cabins across the territory. And so that piece about if somebody needs to leave the health center, the people in that community, if they don't have a vehicle, they should and we should know how to move them. And that has, and so I don't know if I won't go into detail of that, that's very operationally, but that is being looked into.
Mr. Chair, I want to thank you for the question. What it comes down to is in our look, we're going to examine every reason for travel, barrier to travel, and cause for crisis. So sometimes travel is necessary because people haven't been able to maintain that contact with primary care practitioners. Sometimes it's a matter of the practitioner is not traveling to them. Other times it's because they don't have an access to the health center or larger community. So I'm interested in all of that, and I can present it back to you. How we come up with ideas and issues, we'll do this with the teams, with the staff, with the communities, and we're going to also come up with the kinds of changes that we can make within a short period of time. Some of these might be bigger policy issues that need to come back to committee, come back to government, but a lot of these, I'm seeking out those kinds of changes that we can make more immediately to make improvements and return hope to the workplace. Kim Hess, just to follow up.
Ms. Riles?
Oh, thank you. So just very quickly, directly to the member's question, if somebody does need to be seen and they call the nurse in whichever community they are being seen, the community health worker calls in, if there's an agreement that they need to be sent in for a further look, for an x-ray, or perhaps to actually see a nurse or doctor, then medical travel is provided.
Thank you. Ms. Yakala, you've got 30 seconds.
Okay, thank you. The next one is, it's probably operational as well. Looking at elders and home care communities. Some elders are choosing to stay at home. They want to stay at home. They want to age in place or just stay at home. But they don't have people to give them a ride to the health center because the health center nurses cannot leave the buildings. So is there an opportunity here to look at maybe getting a car for healthcare or home care workers that can be on call after hours so they can support the elders in the community. There's a safety issue there, and some elders have been talking to me about it, and they are quite concerned. So am I. So that's why I'm bringing this up now. Thank you.
Madam Minister?
Yes, and you know, and I think that's the thing, that one of the things that we're doing is we're rolling out across the territory as we're able to get the funding, and based on the needs of the communities, and that's done through the home care, the regional home care. They do the assessments of what the needs are in each of our communities and what kind of staffing is needed in those communities. So we've been expanding in some regions where they need after hours and weekend care. So if a nurse, you know, if there's a home care client and the home care client is being visited by the home care worker and they need to give them a ride in for an appointment or things. But when it comes to emergencies, this is one of the areas where myself and Minister MacKay are continuing on looking at possible solutions for small communities. Thank you.
Thank you, Minister. And that will bring our public hearing to a close. Obviously, I think there's many more questions for your department, for the authority, for the administrator, and those will come in due course. But thank you for making time today and for, I think, being very frank with this committee and the public on your commitment to solve the issues and your passion towards those things. I think we'd all be a little bit more comfortable if there were more concrete actions presented for consideration, but we will eagerly await those in the coming week, so I suppose, and months when, and later in the month when we get into our legislative sitting. But I'll allow, Madam Minister, if you want to close with any comments you have.
Thank you, Mr. Chair, and thank you to committee. And one thing that I would just like to say is that my staff and myself, you know, when it comes to this and ensuring that there's much information that we can provide to the public on the work that either the department is doing, even the priorities that where we're focusing on, the ongoing work that's going on in the, you know, within the public administrator's file, and we're always willing to be able to present in front of committee. So I would just like to make sure that and everyone knows that we're more than willing to try and share as much communication as we can and to allow the public to know the work that we're doing, and so that we're more transparent in that way. Thank you, Mr. Chair.
Thank you, Minister. Committee will take a 10-minute break. Thank you. Oh, and this concludes the public portion. Thank you for everyone who tuned in. It's always happy to have an audience for our proceedings, and we hope you were able to gain some important information. And if you have any questions or concerns, please reach out to the Standing Committee on Social Development. We'd be happy to hear your feedback. Thank you.